Good afternoon, colleagues, and welcome to our weekly department meeting. So similarly to last week, this week we will have a suite of 3 exciting clinical cases that will be delivered by members of our department. For those of you who are all COVIDed out, you'll be excited to know that we will be talking about aspects of clinical medicine that are non-COVID related this week. And so the presentations are from the divisions of neurology, cardiology, as well as medical gastroenterology. And I'd like to introduce the first on behalf of the Division of Neurology, and her case is titled No Room to Move. Please go ahead and share your screen, Dr. Soni.
Okay, I will do so, Prof. Thank you.
Wonderful. And if you're able to put on your video, that would be even better.
Okay, let me try.
Wonderful.
Yeah. Having trouble with the video, is that all right?
Not a train smash. Please go ahead.
Cool, thank you, Prof. So our case is titled No Room to Move. It's regarding Mr. C.O., a 46-year-old gentleman of Nigerian descent who's a taxi driver by day. So he presented to us with no chronic illnesses, an RVD and status unknown, and sober social habits. When he presented on the 22nd of May, he had a 2-week history of vertical diplopia, as well as gait instability and falling over to his left side particularly. He's reported that this was an acute sudden onset, there was no progression of symptoms, and there was associated constitutional symptoms, including loss of appetite. There was no associated headache, nausea, vomiting, limb weakness, vertigo, oscillopsia, or speech problems.
Eddie, help. We can't move the thingy on.
Sorry, just trying to get to the next slide.
Yeah,
the video is working, but you have to sit in front of the machine. You must sit in front here.
So, on examination, he was a clinically well-looking gentleman. He was a clinically well-looking gentleman with no wasting or palpable lymphadenopathy. Oral candida was noted. There was an unremarkable cardiovascular and respiratory exam, and that was what we noted in general. On CNS, his higher functions were intact with good cognition and normal speech. He had normal food and mood and affect and no meningism with normal fundoscopy and limited visual acuity bedside testing. His cranial nerves were intact with noted no ophthalmoplegia, and he had normal power, tone, and reflexes noted globally with sensation intact. The cerebellar signs he did have was horizontal nystagmus, more on the left than the right, with a broad-based ataxic gait, and left dysdiadokinesia and dysmetria. So our clinical assessment at this stage was a 46-year-old gentleman with oral candida with a subacute onset of left cerebellar syndrome. Moving on to investigations, he was a newly diagnosed RVD positive with a CD4 count of 44. On note of negative examination investigations was a malaria screen, CLAT, a TB antibody, and hepatitis C studies that were negative. His toxo IgG was positive with a titer of more than 300, and on admission he did have mild LFT derangement with an ALT of 71 and a GGT of 159. CSF results on admission showed a decreased glucose with a protein of 1.08, 0 polys and 48 lymphs. On note of that, on negative findings were the FTA, gene expert, viral panel, and CLAT, VDRL, and JC virus, which were all negative. His cytology showed a moderate hypercellular CSF with mononuclear cells. So this is just his chest x-ray, which we thought was important to show, just to show significantly no overt signs of pulmonary TB. I then wanted to share the MRI that was done on the 26th of May, and Dr. Murray, my consultant, is just going to comment on what was found on that MRI.
Okay, so this is can you hear me? This is a T1 weighted image with contrast, and what you can see, and unfortunately it looks a bit better if you see multiple slices, but you can see this heterogenously enhancing lesion in the right thalamus, as well as this meningeal-based ring-enhancing lesions at the left cerebellopontine angle, and there's also a small enhancing lesion in the rest cerebellum. There was also a pontine lesion, but basically, yeah, so we'll continue, we could discuss later, yeah.
So we also did an abdominal ultrasound, which showed no hepatomegaly, and there were no discrete focal liver lesions or no signs of abdominal TB. He at this time had improvement of his dysmetria in the ward, and nystagmus was unchanged. We started him on Rifafol and cotrimoxazole on day 7 of his admission. This was done in consultation with ID. And at this point, we did not start prednisone as the patient was well, and our plan was to do an interval scan planned at 2 weeks. Sorry about that. It's just our division laptop. Go back. So I just wanted to summarize what was happening up until now. On the 8th of June, this was 17 days into his admission, we had a 46-year-old gentleman newly diagnosed RBD positive with a CD4 count of 44, and he now had multiple intracranial lesions on day 12 of TB and toxo treatment with an aim to repeat imaging at 14 days. He also had a hepatomegaly with mild LFT derangement. So we did the repeat MRI the next day, and Dr. Murray will comment on that in a bit. And what was basically noticed was improvement, but unfortunately, immediately after the MRI, our patient deteriorated clinically. He developed this diffuse erythematous rash, had temperature spikes, abdominal pain, and nausea and vomiting. And it was assessed that he had developed a DRESS syndrome. In consultation with dermatology and ID, all of the drugs were stopped, and the patient was treated symptomatically.
Yeah, so this is just showing the initial scan where you can see this hypodense lesion that on repeat imaging showed a decrease in size, and it was also less enhancing, and the same was seen with the infratentorial lesions.
So I just wanted to make a quick comment at this point on what DRESS is. It's a drug reaction with eosinophilia and systemic symptoms, and usually occurs 2 to 6 weeks after the initiation of the drugs. There are a number of criteria that are out there that you can use to classify a DRESS. We decided to use Bouquet's criteria with just having 3, a skin eruption, which our patient did have, which looks similarly to the one on the right. Blood eosinophilia, which our patient also had, with an eosinophil count of more than 20%, or the presence of atypical lymphocytes, and then there would also be internal organ involvement, including lymphadenopathies, hepatitis, interstitial nephritis, pneumonia, or carditis. So Mr. CO did fulfill all of these criteria. Usually the treatment for DRESS is identification and prompt withdrawal of the offending drug and supportive measures, including fluid, electrolytes, and nutrition. So I wanted to talk now a little bit more about how we managed him. So now he had developed the DRESS. Over the next week, he had the rash improvement, but he was still agitated. So he wasn't exactly confused, but he was very eager to go home, wasn't understanding his diagnosis, and even signed RHT for 1 day during this time. He had a deranged LFT with an ALT of more than 5 times the upper limit of normal, and this peaked on the 15th at 429. Following this, over the next week, he then had LFTs on the downward trend. He was still clinically doing well, and the INR and total bilirubin at this time remained normal. In light of this, on the 26th of June, and this is 2 weeks post the onset of his DRESS syndrome, it was decided that he would be moved to the dermatology ward for reinitiation of his TB treatment, and on this day, INH was initiated. So on the 1st of July, this is 4 days after the initiation of INH, he was still clinically well, his LFT was static, and rifabutin was initiated. However, the next day, we were called to the ward to assess the patient. And what we noted on examination was that he had a decreased GCS. At that time, it was 12 out of 15 since the morning. He had elevated BPs, and there was a concern regarding the progression of his intracranial lesions, as well as the need for an urgent CT brain needed. At this time, he was combative, and it was not the same as being agitated as he was earlier, was refusing medication and food. So the next day, the CT brain was repeated, and we'll look at that image in a moment, but the patient was just not doing very well, required an NG for feeding, and he was clinically deteriorating quite fast.
So here you can see the follow-up scan, and I think it's 40 days since the initial CT. So this is the initial CT that was uncontrasted, and this is the contrasted CT.
You to use your arrow to just show the landmarks.
I'm using my arrow. I don't know why it's not coming up. I'm not sure. It's on our screen. The arrow is moving.
Let me try.
Not a trace, don't worry if it's not moving.
It's just trying. Okay, so but what you can see on the right-sided image is that was the initial image, is there's a lot of space around the brain stem, which on the left-sided image, which was the most recent image, with contrast, there is no space around the brain stem. So there's a massive increase in swelling of the brain, and the patient at this stage was clinically conic.
At this time, it was 1 month post the onset of his DRESS syndrome. Unfortunately, the patient had a worsening clinical condition. He had elevated BPs throughout his stay. We moved him back down to the neurology ward, and there was evidence of cerebral edema. We decided to start IV agents at this time. It was moxifloxacin, linezolid, and Dexa, and INH, and the rifabutin was continued NGT, and unfortunately, he demised on the 13th of July. So just a quick note, I just have one slide on this topic. And what I wanted to say is when it comes to the literature with regards to TBM and DRESS, there's a paucity of literature in this regard, and there wasn't any paper that I actually could find it. But there is a little bit more info on TBM and drug-related events. So the British Infection Society guidelines, and that was published in 2009 by Guy Thwaites, actually addressed this problem. And what they said is there's a lot of striking lack of evidence in this regard, but what they did decide is that treatment interruptions is an independent risk factor for death from TBM, and that there are usually 2 practices in clinical practice, but neither of them are actually supported by evidence. So the first one is to stop INH, RIF, and PZA immediately if the serum transaminases are more than 5 times the upper limit of normal. But as you will notice, in that regard, even then, ethambutol is still continued. And then the practice of the second group of clinicians is to stop INH alone if the transaminases are more than 3 times the upper limit of normal. So in this paper, their recommendations are firstly, the threshold for stopping RIF and INH should always be high in TBM, even when there are drug-related events. Secondly, if the transaminases are more than 5 times the upper limit of normal, you should stop pyrazinamide but continue INH and RIF and ethambutol and do daily LFTs, which is what we were doing, but we had stopped all the drugs. And the third thing is if the serum albumin falls, the PTT rises, or the transaminases continue to rise, that INH and RIF should be withdrawn. And then you should still keep the patient always on 3 drugs, and that will be streptomycin, ethambutol, and then either moxi or levo, especially when there's severe disease and TBM, which we regarded as severe disease.
Sorry, can you see me? Oh,
Yes,
Yes,
we
Suzanne.
can.
okay. Hi, everyone. So thanks, Aisha. That was a nice presentation. So I just wanted to raise one main issue in patients with TBM is the difficulty, and I think the title summarizes it nicely, no room to move. It's patients with TBM do not tolerate discontinuation of TB drugs in the same way that patients with pulmonary TB does. And the first knee-jerk reaction when a patient presents with a severe adverse drug reaction is to stop TB drugs. And this, what Aisha said, was initially showed in the DEXA trial by Waiting, that was published in 2005, I think, that they showed that drug interruptions is independently associated with poor mortality. And recently, more and more trials are actually not necessarily in DRESS, but looking at trying to avoid stopping TB drugs in patients with DELI due to TB treatment. And they actually are seeing, and this results will come out shortly, that if you just keep a patient on the TB medications until the limit is more than 10 times normal, patients actually recover spontaneously. So they have shown that you can push the envelope further because it is really important to keep patients on their drugs. Now, with regards to DRESS, the dermatologists will comment, but I think the same principle should apply, that we should try and change patients to alternate drugs, but not let patients go without any TB drugs for any period of time. Thanks.
So thank you very much, Aisha, as well as to you, Suzanne, for those comments. I wonder if I can invite Janine Heckman to comment as the consultant on the case.
Yes, thank you very much to both, to Suzanne and Aisha. I have to say that Suzanne was not involved in the case, but I asked her to comment as our neuroinfectious ID person. And I think, you know, it underscores the importance of having somebody with 10,000 hours of TB experience on the team. I would like to before maybe we close, ask the dermatologist if Ranks just wants to, he was also peripherally involved in this case, and I think he perhaps has something also to add from a dermatology point of view. And perhaps before he comes in, the reason that we are presenting this case is to highlight that the brain is a different kettle of fish, and that we can't just use the same algorithms as one would use in the liver or elsewhere. But perhaps Ranks just wants to also talk about what happens in the skin.
Hi, thank you so much for this, because it's I hope you can hear me.
Yes, we can.
It was a very worrying case for us, and it was actually out of our normal routine. And it's the main problem that we had with this patient was that when they came to us, the main concern was whether they needed steroids or not while they were off treatment. And the decision that I made when I initially decided to restart them on treatment was that we were going to do a very rapid re-challenge, because normally for you to be able to pick up a reaction to any medication, it takes about 4 days. So we decided that we would give him INH and RIF within a very short time. So he tolerated INH, but then immediately reacted to RIF. And then we've shown before that there is no cross-reactivity with DRESS and SJS to rifampicin and rifabutin. So we gave him rifabutin. And then once that was done, then the whole idea was then just to reintroduce all the other four drugs as soon as possible. And when I saw the patient was, this is in the brain. What's going to happen? And I tried to explain to him that our biggest worry was what's going to happen intracranially, both the edema and the spread of the TB versus the rash. The rash is not that important in this context, but he was worried about the rash at that time. And it was one of the reasons why he wanted to sign the form to leave the hospital. But I said, the rash is the least of your concern. And I think he failed to understand that. But I think where we would need advice and to really look at this is that when we're discussing it is that in normal medication, INH is sterilizing. It's the most rapid one that you get the improvement. But we were sitting in a situation where, first of all, we didn't know whether they needed systemic steroids to try to suppress the edema. Secondly, we are not sure of the penetration of the treatment in terms of CNS, whether RIF, INH, RIF, PZA, and ethambutol in that order were the most important. I think that's one of the things that we could not really got grips of, which is the ideal treatment that we should use. And normally what we do is before we start anybody on treatment, once we stop the 4 drugs, we give them a backbone of 3 other drugs that they have not been exposed to, so that they don't spend any time without being on any drugs. And at that point, we decided that we really need to get this done within 4 days. So our idea was that within 4 or 5 days, we should at least eliminate the offending drug, which turned out to be rifampicin. Now, that's the last point. The problem with DRESS is that in our setting, all the 4 drugs cause DRESS. So there is none that is more predominant than any of the other the 4 first-line drugs. RIF, INH, PZA, and ethambutol, all of them can cause DRESS. And we do wait until they are 5 times the upper limit of normal, because even when you got rifabutin, his liver enzymes went a little bit up, but then they settle soon after that. So I think the learning point out of this is probably there should have been better coordination between us and the neurologists in terms of, did he need steroids? And what is really the ideal drugs if somebody presents with CNS TB that are the most effective to start with as compared to the other things. And unfortunately, I still don't have a good grip of what are the most effective anti-TB drugs that will have the most benefit when in cases of TBM.
Okay, thank you very much. I think that the bottom line is that you and that dermatology and neurology seem to be singing from the same hymn sheet, and that is that in a patient with TB meningitis, the patient should not go without anything, that you cannot stop all the drugs. And that is what Suzanne also, once we got her involved, is what she said, is that we have to replace it with another drug. And that's exactly what you said. And that's what the British Guidelines for Infectious Society also says, that, that you should, if you are going to stop any offending drug, make sure that the patient is on something. And you should ideally be on at least 4 drugs. So I think that really is what we wanted to highlight, is that TB in the central nervous system has got a terrible prognosis, and if you start stopping treatment, it becomes an independent risk factor for death.
Thanks very much, Rens and Janine. Biko, you've got your hand up. Let's go ahead.
Yeah, mine's might be a minor point for clarification. This patient presented with vertical diplopia. Can someone explain what caused it, sort of given the CT findings, et cetera, et cetera? What was the cause of the vertical diplopia? It seemed that they didn't have any.
So we actually, even though he did complain of that, we couldn't find any evidence of vertical disalignment on examination. Because of we didn't show you all the images, but he obviously had vertical diplopia. Usually is because of involvement in the superior aspect of the brainstem, so the nucleus of Cajal, right next to the, so in the diencephalon, so really where the thalamus is. And he did have evidence of a space-occupying lesion there with edema, as well as the outflow tract of the superior cerebellopeduncle. So he certainly had disease there, but we were not able to find evidence of that on examination, although he definitely did complain of that intermittently.
Okay. Thank you. I forgot to say, very, very nice case. Thanks.
Well, thanks very much, Janine, for that very instructive and important message on this case. And thanks to Aisha for the presentation. So I'd like us to move to our next presentation for the day, which comes from the Division of Cardiology. The presenter is Dr. Jama, and he is presenting on a case titled Left Main Stem Lesion or Left Main Equivalent, and Professor Chin is the consultant. Would you like to share your screen, Dr. Jama? Please go ahead. You can go ahead and start.
Good afternoon.
Do you want to switch to presentation?
I'll be presenting on behalf of the cardiac clinic.
Do you want to?
Jama, and the consultant of this case is Professor Chin. We're going to share with you our experience with the case that we saw early in March this year.
Zemasa, before you continue, do you mind just clicking on your left? To your left, there we go.
Okay. The index case is a gentleman, 66 years of age. He's a widow and father of 3 children. He's an ex-smoker, stopped about 2 months prior to presentation with 30-pack year history of smoking. He had a class 2 baseline limited predominantly by shortness of breath. This was his background. He was hypertensive and diabetic with dyslipidemia. He suffered a vascular event in 2018, of which when he presented to us, he had complete resolution of that. That was the medication which he was on chronically. On family history, he alluded to the fact that his father died at the age of 50 suddenly, which we're not sure what was the cause of death. He presented in one of the private facilities in the Western Cape with a day history of epigastric discomfort with associated nausea and vomiting and diarrhea. He denied any chest pain and any decline in his shortness of breath. He said there was no change in his shortness of breath. He was not coughing, there was no sore throat or any known positive contact with COVID. But he presented just before our first case of COVID. He was early in March. We don't know if he was exposed at that time when we started testing. In the private facility where he presented, this was his vital signs. As you can see, he was tachycardic at 120 beats per minute, paraxial at 38.8. Although he was saturating fine at room air at 96, respiratory rate, he was not tachypnic, at a respiratory rate of 16 breaths per minute and normotensive. And on his investigation, a chest X-ray was normal and his labs was normal. This was his ECG on the at the presenting hospital. What you can appreciate on this ECG, he's in sinus tachycardia at 120 beats per minute. At 120 beats per minute, it's a narrow complex tachycardia with normal axis at about 30 degrees. Of note, what you see, I'm not sure if you can see my arrow, but what you can see on this ECG, she's got the concave ST elevations on the right precordial leads involving the AVR lead V1, V2 with T-wave inversions, and quite significantly horizontal widespread ST depressions after 60 millimeters from the J point, involving the lateral leads and the high lateral leads there. At the peripheral hospital, obviously, the person who looking after the patient at this stage, regardless of him not presenting with chest pain, he was worried about the ECG, and he put up a troponin. That was the point of care troponin, which was measured at 130, and that was the reference, which showed it's more than 5 times upper limit of normal on a range of myocardial ischemia. The summary is a 66-year-old, as we've mentioned, with vascular risk factors and a previous vascular event. He presented with a febrile illness with a high-risk ECG and a troponin leak. It was discussed with us, the ECG was sent across. What was going through our mind was that regardless of this patient, he had an epigastric pain, not chest pain, and a diarrheal illness and fever. But the ECG was suspicious. We thought that he might have had type 1 myocardial infarction. Looking at the ECG, we were concerned about left main stem disease or left main equivalent. Or was this a type 2 myocardial infarction? Did he have a pulmonary embolus? As you could see on the ECG, he was going at about 120 beats per minute in sinus rhythm with ST elevation in the right precordial leads. Or was this a Brugada phenotype? On our speculations, we thought pulmonary embolus was less likely, regardless him being in sinus tachycardia. Because he didn't have any chest pain, he was not tachypneic. His SATs were about 96 at room air, and his echo didn't show any features to suggest a massive PE to correlate to what the ECG changes. We consider the left main, that you have a left main. Yes, he's got vascular risk factors. He's 66, he's male, he's been diabetic for years, cholesterol. He had a previous vascular event before and hypertensive. ECG was at AVR elevation with white weight acid depression with the troponin leak. Other consideration was that of Brugada syndrome, because of his right precordial leads concave ST elevations. And then the fact that he had a febrile illness that might have possibly unmasked the ECG pattern. Obviously, I think everyone would have taken this patient to the lab to just make sure that there is no left main disease. Of those that are not familiar to look at the angiograms, this is an angiogram showing your left coronary system. This is your left which is clear and doesn't show any low limiting disease. That's your circumflex and that's your LAD on the other side. So it's a mild disease that you see in the proximal LAD there, which we didn't think was responsible for his presentation. On this side, on On the other side, you see this is a left ventriculogram, which doesn't show any regional wall motion abnormality. And also, his end diastolic pressure was within the normal range. It makes it less likely that he might have possibly had an event. This is just to show you an ECG and comparison between our index patient ECG and a person who has a left main. This is not him, the angiogram. This is somebody who presented to us sometime last year with no chest pains. He had a history of syncope, which we found that he had got a severe left main disease. This was his ECG. What you appreciate on these two ECGs is the similarities between the two ECGs, as you can see on the top part, the top ECG with widespread horizontal ST depression, which we saw in our patient, and ST elevations in the lateral, in the right precordial leads AVR and V1, which we saw in our patient. Hence, we entertained the diagnosis of most probably this patient might have left main disease, but we will allude to the subtle differences of this as we go along in the presentation. I would like to introduce to you the concept of Brugada syndrome. What is Brugada syndrome? Brugada syndrome, as all of you might know, it's a channelopathy with autosomal dominance inheritance, predominantly in patients that have a structural normal heart. It is caused by mutations in predominantly 3 channels in the heart. It's a loss of functional mutation in sodium and potassium channel and gain of functional mutation in potassium channels. Its prevalence is unknown. The Brugada pattern ECG incidence is about less than 1%. It's responsible for about 5% of sudden cardiac death. But in 20% of those sudden cardiac death, they have structural normal hearts, and is predominantly found in men in 8 to 10 times more than women. Brugada syndrome, its mechanisms are not yet clearly understood, but it's been hypothesized that it might be related to the repolarization hypothesis. What is the repolarization hypothesis? If you look at the first column here under A, these, if you remember your physiology, these are action potentials in the heart. There are 3 lines. There's a red, there's a blue, and a black one. It resembles the 3 layers of the heart. The black one is the epicardium, the red one is the endocardium, and the green one is the myocardium. Normally, your distribution of your channels within your heart are evenly distributed amongst the 3 layers of the heart. In Brugada syndrome, because of the mutations of those channels, there is a transmural voltage gradient between your epicardium and your endocardium, meaning that the mutations are predominantly in the epicardium, where you see less of your sodium channels and the gain of your potassium channels. That creates a gradient between the epi and the endocardium that is responsible for what we see in Brugada syndrome, that concave deceleration of your ST segment, as what's shown on the ECG in the bottom. And then that...
Jama, if I can ask you to start wrapping up so we can have some discussion of the case.
Sorry?
Start wrapping up so we can have some discussion of the case.
Yes, well, towards the end of the case, yes. That's That's what you see in patients with Brugada syndrome. This is a classical ECG of a Brugada syndrome. It's got this concave ST segment elevation with ST depression that you see in the high lateral leads. But if you notice here, the ST depressions are quite upsloping ST depressions. It manifests as shown on the slide. Predominantly, the majority of this is they're asymptomatic, but about 5% they present with sudden cardiac death. What is recommended is that if you have a Brugada looking like ECG in a patient, they should avoid Brugada drugs, which you find them on that link. They must avoid alcohol and fever. You must treat fever with antipyretics because fever and alcohol inactivate your sodium channels. What is also recommended is that in patients with Brugada syndrome, you can only implant ICDs if they have sudden cardiac death, aborted sudden cardiac death, or they have VT on unexplained syncope. Ablation is only for repeated shocks as a palliative procedure. Then what happened to our index case? If I were to show you, this is the classical Brugada, and this is our index patient. What you notice here is the concave sort of ST segment depression, which confirms that this is most likely a Brugada pattern. But what was unusual was the ST depressions with the horizontal on the high lateral leads. That's your left main syndrome and your Brugada. What you see on the left main is that the STs are more saddle shaped and more horizontal than down shaped ST segment. What happened to our patient? When he arrived to us, he had no fever anymore. His temperatures were fine and the diarrhea has resolved. He was advised on dietary on lifestyle modification. Indapamide was stopped as it one of the drugs implicated to worsen the Brugada ECG pattern. He was referred for genetic studies and is due to follow up in the EP clinic. My take-home message is simple. Although most of you will be able to pick up Brugada ECG when they are faced with, but remember to rule out the mimickers, more especially in a 66-year-old with risk factors. Brugada is a diagnosis of exclusion. Thank you.
Thank you very much, Zimasa. Ashley, would you like to make some brief comments on the case?
Thanks, Ntobeko. No, Zimasa gave a great talk there. I mean, we see getting referred, quite a few patients with the Brugada pattern. Most of these patients require nothing more than lifestyle counseling. We've got about 5 to 10 patients who have received ICDs for sudden death from this condition. So I think it is something that you need to be aware of, especially a young patient who presents with sudden death with this normal structural heart. We need to exclude this particular pattern. So Masa quite eloquently showed the differential diagnosis of a patient who presents with ST segment elevation in V1 and AVR. There's only a few cases few conditions that cause this. By far the most common in someone with chest pain is diffuse myocardial ischemia, as you saw in that ECG. So diffuse ST segment depression with reciprocal ST segment elevation in V1 and AVR usually suggests a critical main stem or a left main equivalent. And the reason why we showed this case is it's quite important that Brugada is a disease of exclusion. So it was quite important here in someone with vascular risk factors to exclude someone with a left main stem lesion. So that's one of the reasons why we looked at did an angiogram. But I think he also eloquently showed the reason why this particular patient had a characteristic pattern for Brugada. And just finally, the importance of treating fever in patients with Brugada. Fever not only can worsen the Brugada pattern, but can also precipitate arrhythmias. And I can distinctly recall a case that we had a couple of years ago where a patient who presented with Brugada in a VT storm, where we gave paracetamol to, and which completely settled their arrhythmias. So paracetamol can be a potent antiarrhythmic drug in this particular condition. And then just lastly, in the era of COVID, there's several case reports now of COVID unmasking the Brugada pattern. So we might see some patients who've never been diagnosed with this condition, but just with a fever, present with some condition. Thanks, Mr. Becker.
Thanks very much, Ashley. So in the interest of time, we're going to move to our last case of the day, which is from the Division of Medical Gastroenterology. And Professor Gillian Watermeyer will be the presenter on a case titled "A Diagnosis That is Easy to Miss." And I'm sure that is many of the conditions that we see. Over to you, Jill. Would you like to share your screen? Jill, are you there?
Cameras on.
Please go ahead.
Okay, hi there. Sorry. Can you hear me? Hi, Ntobeko, can you hear us?
Yes, we can.
Yes.
Okay, great, thanks. Okay. Gosh, why is this not going, moving on? Okay. Hold on, we're just having a few, sometimes it takes a while to let you advance. It was fine when I tested it earlier. Okay, great. Okay, so the case I'm going to present is a 40-year-old man. He is a professional waiter. He's married with one child, and he has no past medical history of any note. He has a rather unfortunate orthopedic history, however, in that he had a motor vehicle accident in 2013 and fractured his right tibia and required an external fixator. And this was complicated by sepsis, and over the following 4 years, he had multiple surgeries involving wound debridement, skin and bone grafts, leaving him with chronic, severe, intractable right lower limb pain. And this was very incapacitating, and in fact elected to have a below knee amputation in 2017. His orthopedic problems didn't stop there, and in 2018 he fell, and he fractured his right neck of femur and had a dynamic hip screw. About 8 months later, he presented to casualty with about a 3-day history of nausea and vomiting, abdominal pain and constipation, and he was diagnosed with a small bowel obstruction, and you can see his x-ray there showing dilated loops of small bowel and air fluid levels. And he underwent a laparotomy by our acute care surgery department, which no cause was found for the small bowel obstruction. But what the surgeon did note was that there were thickened proximal small bowel loops and large mesenteric lymph nodes, which were in fact removed. And the histology was not helpful. It showed benign lymphoid hyperplasia, but tuberculosis was excluded. The surgeons at this point were not sure of what the cause of the small bowel obstruction was. They thought that possibly it was an intermittent obstruction and that by the time they did the laparotomy it had resolved, or a non-mechanical obstruction. Now, over those many years that he was seen at Groote multiple hospital admissions, follow-up visits, he was noted to have a persistent iron deficiency anemia, with his HB sort of hovering between about 5 and 7, marked microcytosis and thrombocytosis. He was also on occasion noted to have a folate deficiency, but a normal B12. Now, prior to his below knee amputation in 2017, he underwent a colonoscopy, which was normal, and a gastroscopy, which showed a grade B reflux disease, which was treated with a PPI. He also received periodic courses of oral iron and folate, but beyond that, really, this was not taken any further. And he finally wended his way to our clinic in March of 2020 for workup of this unexplained iron deficiency anemia. So when I saw him, which was just before lockdown, he had infrequent heartburn and dyspepsia, but he denied dysphagia, nausea, vomiting, hematemesis or melena. He had a normal appetite. He had not lost weight. There was no diarrhea, constipation, blood per rectum, abdominal cramps. He also had no extraintestinal manifestations of anything, and he had a normal diet. When I examined him, he was a very healthy man. He had a BMI of 20, and his examination was unremarkable, other than a little bit of pallor and right below knee amputation and his laparotomy scar from his small bowel obstruction. So these are the bloods I did, and he had a full blood count, which confirmed iron deficiency anemia, HB of 7.5. Ferritin and folate were both low. but his B12, his renal functions, glucose, and TSH were all normal. On his liver function tests, everything was unremarkable except for a marginally elevated ALK phos. And he then underwent a gastroscopy. And as in 2017, this showed grade B GORD. He also had mild gastritis and was RUT positive, so his Helicobacter pylori was eradicated. He then also went on to have duodenal biopsies, which is customary in all of our patients who are scoped for iron deficiency anemia. And what you see there is severe villous blunting on the second part of the duodenum. And if you just compare that with the histology on the other side, which is a normal duodenal biopsy, you can see those lovely villi. His anti-tissue transglutaminase antibody came back as very strongly positive, probably the most positive I've ever seen. And his anti-deaminated gliadin peptide was also positive. So this confirms very strongly a diagnosis of celiac disease. So celiac disease, I'm sure you all know, is an immune-mediated inflammatory disorder of the small intestine. It's triggered by the ingestion of dietary gluten, which is found in wheat, rye, and barley, in genetically predisposed individuals. So there's a strong association with HLA, DQ2, and DQ8. And in fact, if a patient does not possess these, they do not have celiac disease. It's got a very high negative predictive value. The autoantigen involved is the ubiquitous enzyme tissue transglutaminase. And it's especially common in patients who have first-degree relatives like our patient. In fact, 10% of first-degree relatives will have celiac disease. And it's also very common in type 1 diabetes and patients with autoimmune thyroid disease. So celiac disease can manifest at any stage of life, from early childhood right up into the octogenarian years. Can present with the classic symptoms related to malabsorption, which is things like diarrhea, steatorrhea, and weight loss. These are in fact very rare presentations in the adult. This is much more common in pediatric celiac disease. Much more common is IBS-like symptoms, bloating, cramping, diarrhea. But in fact, the majority of adult patients with celiac disease are asymptomatic or exhibit very minor GI complaints and have extra-intestinal manifestations only. And these extra-intestinal manifestations can affect pretty much every organ system, which is why these often are seen by non-gastroenterologists. The classical rash, dermatitis herpetiformis, which you can see it's got those herpetic-like vesicles, aphthous Moll's ulcers, unexplained ataxias or peripheral neuropathy, unexplained increase in transaminases on liver function testing, infertility, miscarriages, unexplained osteoporosis, and as in our case, unexplained anemia. So through the retrospectoscope, which is always very easy, the clues to the diagnosis in this case, he had a family history of celiac disease, his aunt. He never knew about this, but that was only because he'd never asked about it before, and he didn't realize the importance of this detail, so he never volunteered it, as our patients don't, if they don't understand the importance. The fact that he had both iron and folate deficiency makes you think that this is a malabsorptive process rather than iron deficiency due to GIT blood loss. He had a fractured neck of femur, and he's a young man. After a very minor fall, must make one think about osteoporosis or osteopenia, because this is the type of fracture that you typically see in the older, frail patient who has osteoporosis. And unexplained small bowel obstruction with these large mesenteric lymph nodes and proximal small bowel, which is thickened, rare but well described in celiac disease. So the three main challenges in this condition is who to screen, how to screen, and how to treat. So who to screen? Asymptomatic patients, first-degree relatives would certainly be reasonable to screen them, and type 1 diabetics, because about 10% of them will have celiac disease. Patients with GIT symptoms, the classic symptoms of diarrhea, loss of weight, malabsorption, or patients who have symptoms suggestive of irritable bowel syndrome, especially the diarrhea predominant variant, and those patients with unexplained extra-intestinal manifestations. How do we screen? Well, the preferred single test is an IgA tissue transglutaminase antibody. What we used to do a few years ago was the IgA anti-endomysial antibodies, and these are great because they're highly specific for celiac disease, but they're extremely expensive. So we've moved just really to doing the IgA TTG. But where the endomysial antibodies are very useful is if you've got a borderline anti-tissue transglutaminase antibody. Very importantly, about 5% of celiacs are IgA deficient, which is going to mean that your IgA tests are not going to be of any value. So you need to do an IgG test, and this can either be the IgG deaminated gliadin peptides or an IgG TTG. They are not as good as the IgA tests, but in IgA deficiency, they have to suffice. Very important as well is that serological testing should be done while patients are on a gluten-containing diet. Patients who are on a gluten-free diet or restricting gluten can have false negatives. So if you're going to do these tests, and they're not all that cheap, make sure that you have a patient on a diet that is containing gluten, and if they have been reducing gluten, then to give them a gluten challenge, at least 3 slices of bread for about 3 to 4 weeks. The duodenal biopsy is the gold standard for the diagnosis, and it should be performed in patients who test positive on serology, or if there's a high index of suspicion, even if the serology is negative. And again, as with the serology, it really should be done in patients who are taking a gluten-free diet. Sorry, a diet with gluten. Okay, so we classify the histology of celiac disease by what's called the Marsh classification. Marsh 1 is intraepithelial lymphocytes, which are increased, more than 25 per high power field. Marsh 2 is where you see crypt hyperplasia. You can appreciate that those crypts are much longer than the ones preceding them. And Marsh 3, which is villus atrophy. So our patient had complete villus atrophy, which is a Marsh type 3C. The diagnosis of celiac disease in adults is definite if you have positive serology and Marsh 2 or Marsh 3 villus atrophy. That is crypt hyperplasia together or without villus atrophy. Unfortunately, celiac disease doesn't always behave itself and doesn't always tick all the boxes. And some examples would be patients who have Marsh 1 on histology, because this is very non-specific and it's not enough to confirm the diagnosis. Equally as tricky is if you have patients who have positive serology, but they have a normal duodenal biopsy, or patients who have negative serology, but they have histology, which looks very much like a Marsh 2 or 3 celiac disease, what we call seronegative celiac disease. And in these scenarios, the simplest thing that we will do is to check for HLA, DQ2 and DQ8, because this is absent, and you really hope it is, then you put the diagnosis out. This is not celiac disease. You don't have to go down that road again. If it is either of them are present, it doesn't exclude celiac disease, but it certainly doesn't confirm it anywhere. And these patients require a workup, which is quite complex, but generally starts with something like a gluten challenge before we will repeat serology or repeat biopsies. So how do we treat? Well, the only treatment is a strict lifelong gluten-free diet. And this has a dramatic impact on improving patient quality of life. It will ameliorate their GIT symptoms. It can correct all those extraintestinal manifestations I have alluded to, as well as prevent complications like small bowel adenocarcinoma and T-cell lymphoma, which are both well-recognized complications of untreated celiac disease. So one must be very careful, and we're very vigilant about this, on only starting a gluten-free diet once a rigorous diagnosis of celiac disease has been pursued. Because this diet is a nightmare. It's a lifelong commitment. It's extremely socially isolating. Patients are hugely anxious if they go to eat at friends' houses or restaurants. There are numerous hidden sources of gluten in foods like chocolate bars and processed meats. There are hundreds of hidden sources of gluten. And I've just put that little picture up there because one of them is fact the medications that we prescribe to our patients on a daily basis often contains starch. And we also have major issues with food product labeling in this country. Not all companies are very good about labeling the gluten content of their food. So patients really must be managed by a dietitian. I think they're just as important as the clinician in making sure that these patients receive adequate therapy. And I think also, most importantly, I don't think we realize how expensive a gluten-free diet is. If one compares here the enormous difference in the cost of a normal loaf of brown bread and a normal a packet of spaghetti compared to the gluten-free ones. So if my patient with celiac disease wants to go and buy a loaf of bread and a packet of gluten-free spaghetti, it's going to cost him 110 Rand. Bear in mind, he's a waiter. His restaurant has still not opened up. He has not earned a thing since the beginning of lockdown. It's impossible. After making the diagnosis, we will then screen our patients and treat any nutrient deficiencies and any other complications. And particularly it's iron, B12, vitamin D, calcium, and folate that we want to know what the levels are, treat them if they're low. We evaluate the bone mineral density routinely with a DEXA scan, and we'll do liver functions. We'll also screen for other associated conditions like type 1 diabetes. We always check thyroid functions in these patients. And we'll consider advising our patients to have their first degree relatives come for screening. We also monitor our patients very closely. They should have resolution of their clinical symptoms on a gluten-free diet. And we also expect their nutritional deficiencies and blood abnormalities to normalize fairly rapidly. Another good way of following up patients is to do serial anti-tissue transglutaminases antibodies, and they should be done at about 6 and 12 monthly and then about annually. And they usually start to normalize within 6 months, and by a year they should be normal. And the real value of doing these serial antibodies is that they're excellent for ensuring that a patient is compliant. If they don't go down, that's number one, is that the patients are taking gluten either deliberately or they don't know that they're ingesting it. But in contrast, normalization of these antibodies does not always correlate with mucosal healing, so we have to be aware of that. So a little bit more controversial, who should have a repeat duodenal biopsy? And we used to always do this, but it's no longer just a knee-jerk reaction. And it is controversial, certainly, whether you need to do this in everybody to make sure that the villi grow again. And certainly recommendations differ between different societies, and many experts believe that it's not necessary to subject patients to another duodenal biopsy, provided they are clinically and biochemically responding well to the gluten-free diet. So who should get a scope? Well, those patients who do not get better, or if they did get better, but now they've relapsed and you can't find another cause. If the antibodies remain elevated, those patients that are seronegative, who you put onto a gluten-free diet, because it's the only way that you're going to know if in fact they really do have celiac disease. And the recent European guidelines suggest that in fact it may not be unreasonable in adults after about 1 to 2 years starting a gluten-free diet to assess their duodenal mucosa. And I think that most gastroenterologists feel a little bit more comfortable doing this than actually never scoping these patients again. So my take-home message is celiac disease is an easy diagnosis to miss. This is because there's a widespread perception that it manifests primarily with GI symptoms, but in fact most patients are asymptomatic or have non-GI issues. So always consider it in the patients with unexplained extraintestinal disorders, because really diagnosing celiac disease and treating with the gluten-free diet may be life-changing. Their quality of life, it's absolutely incredible the difference that this makes. Consider screening asymptomatic patients at high risk, because a gluten-free diet, again, will markedly improve their quality of life, even if they are asymptomatic, and will prevent some of those many complications that I've alluded to. And I think most importantly, be very confident of the diagnosis before committing patients to a lifelong gluten-free diet. There is this entity called non-celiac gluten sensitivity or non-celiac wheat sensitivity. I'm not going to discuss it, but I'm sure you all know people that are sensitive to gluten. They do not have celiac disease, and so we need to be absolutely certain that we're not putting that group of patients onto a lifelong gluten-free diet with all of the disadvantages I've alluded to of that diet. Thanks very much. I'll end off there.
Thanks, Gill, for, as always, an excellent and very educational presentation. Perhaps I can ask 2 very quick questions. Would you like to comment, one, on the prevalence of celiac disease in our context? And secondly, I was really struck by the extent of the iron deficiency anemia and whether that is usual and you expect full recovery of that on this gluten-free diet.
Okay, so for the first question, the prevalence of celiac disease in South Africa is not known. We're still waiting for Sabelo to give us some data on this. We do, however, have a recent study from Prof. Mutala's unit up in Natal, and they looked at patients with type 1 diabetes who were asymptomatic, and she screened them all for celiac disease, doing both serology, and if the serology was positive, by then doing duodenal biopsies. And in fact, she found that 2.5% of all of her type 1 diabetics who were completely asymptomatic had confirmed MARSH 2 or 3 celiac disease. So I think that's, you know, just in our setting, that just highlights the importance of actually screening type 1 diabetics. So that's the first question. The second question, the severity of iron deficiency anemia. Yeah, that's pretty bad. Admittedly, there was also the added component of folate deficiency, but certainly that's absolutely within keeping with severe celiac disease. He had no villi at all.
So I'm happy to open this presentation up for one or two questions before we close the meeting.
Tobacco?
Question, Graham?
That's Graham. Yeah, thanks, Jill. That was great. I just wanted to have your thoughts on what do you think the mechanism of the small bowel obstruction and lymphadenopathy was, and you said that has been described, although uncommonly.
Okay, so yeah, it's a very good question, and nobody really knows the answer because it's extremely rare. This is kind of case report stuff. But what it appears to be is that with celiac disease, you get these very thickened folds of proximal small bowel, and there is some dilatation and some dysmotility, and that this can actually result in interception of some of those thickened folds. I mean, that's very likely what happened because that would be an intermittent problem. The mesenteric lymphadenopathy, nobody knows what causes that, but it's probably just a reflection of quite an aberrant, both innate and adaptive immune, very potent immune response to gliadin in susceptible individuals.
Yeah, that makes sense. Thanks.
Well, if there are no further questions for Jill, I'd like to thank all of our presenters today for excellent case presentations. I found the educational value of all three to be exceptionally high, and to thank all of you for attending. And I'd like to remind all of you, and many will be presenting in the future, if we stick with this platform to try and keep the presentations to about 10 to 12 slides, so that we can allow for focused presentations and adequate time for discussions of these interesting cases. Thank you so much and keep well.
I didn't because I wanted to.
Thank you.
Bye.
Thanks very much.